Good morning. Thank you for inviting me here this morning. It's nice to see everybody, and thanks for getting up early, as Dr. Esteva said. So briefly, I'm going to sort of discuss the eosinophilic esophagitis and other eosinophilic gastrointestinal disorders sort of from a pathologist perspective. Sort of what do we see under the microscope? How do we make the diagnosis, and what are some of the difficulties in making the diagnosis? So I'm going to talk about a little bit about specimen processing. You know, after a patient is scoped, how does that tissue actually make it to the pathologist's microscope? Review of normal histology of the esophagus. Review some of the features of eosinophilic esophagitis and how some of those features are different or perhaps similar to other eosinophilic gastrointestinal diseases or other eosinophilic inflammation in the esophagus, and some of the differential diagnosis of eosinophils in the GI tract. So if you can see here on the slide, number one is actually a small tissue biopsy that you can see in forceps. So we actually make a diagnosis on a very, very small amount of tissue. Sometimes we get 2 or 3 tissue fragments that are only 1 or 2 millimeters. So it's just a very, very small portion of the esophagus. The tissue is processed overnight in various gradations after it's fixed in formalin of alcohol and formalin. And then you can see it's embedded in paraffin up in number 2. Orientation is critical for some of the features of eosinophilic esophagitis, which I'll talk to. And I talk to our histotechs and praise them when they get tissue oriented well, and just make sure that they spend the time to make sure the tissue is properly oriented. The tissue is then cut on a microtome at 4 or 5 microns. It's placed on a glass slide, and then it's stained. And it's that stained slide that we actually make the diagnosis on. So normal histology of the esophagus. Really, the biopsies are only mucosa and perhaps a little bit of submucosa, but there's also the muscularis propria and the serosa, which I'm really not going to talk about, but we're just looking at the mucosa when we look at these biopsies. The mucosa is composed of the non-keratinized stratified squamous epithelium, which has 3 layers. You may also see in the normal esophagus a small number of endocrine cells, small number of melanocytes, and a small number of inflammatory cells, usually lymphocytes, but even occasional mast cells as well. The basal layer, and I'll show you some photographs of this in a minute, is the lowest 10 to 15% of the epithelium, and that is normally only about 2 to 4 cells thick. The upper extent of the basal zone is defined by the region where the nuclei are separated by a distance equal to the diameter. And I'm focusing on that because sometimes the basal layer elongation or thickening of the basal layer is one of the features to define eosinophilic esophagitis. So here's a biopsy of a normal esophagus. It's well oriented. You can see the basal layer. The arrow is sort of at the upper extent of the basal zone. You can see that the basal zone is probably less than, certainly less than about 20% of the thickness of the epithelium. This is an H&E stain section, and there are no inflammatory cells here identifiable. And you can see it as the cells mature, the cells tend to get bigger. They take on more cytoplasm. The cytoplasm is pale and takes on glycogen. So that's a normal esophageal biopsy. The lamina propria is the other part of the mucosa, which is sort of the non-epithelial part of the mucosa, up above what we call the muscularis mucosae. It's composed of connective tissue, some small blood vessels, and small numbers of inflammatory cells. And the vascular papillae, which I'll show you in a minute, are an extension of the lamina propria that go up into the epithelium. So here's another biopsy of the esophagus. You can see that it's well oriented. You can see a very narrow basal zone, and you can see that these, I guess the arrow isn't working here, but you can see these sort of extensions of the lamina propria with the vascular papillae that goes up into the epithelium, and they carry blood vessels. There are small numbers of inflammatory cells there as well. So that's a normal biopsy. Here's another biopsy. We can actually see a little bit more lamina propria, and you can see some connective tissue, some small blood vessels, and some inflammatory cells, and that's certainly perfectly normal there as well. So what do we see in eosinophilic esophagitis? Well, of course, we see increased numbers of eosinophils. We frequently see eosinophilic microabscesses. We see superficial layering of the eosinophils. We see free eosinophil granules or degranulated eosinophils. We see basal zone hyperplasia, elongation of the vascular papillae. We often see edema between the cells or an increase in space between the cells. Rady peg elongation or extension of the Rady pegs into the lamina propria. And often we see fibrosis and eosinophilic inflammation in the lamina propria. In eosinophilic esophagitis, as opposed to some other disorders where you see eosinophils in the esophagus, those changes tend to be throughout the entire length of the esophagus, not always, but frequently. With few exceptions, 15 eosinophils per high-powered field as a peak value is considered the minimum threshold for a diagnosis of eosinophilic esophagitis, and we often see many more, but I think there are certainly patients that may present with fewer than 15 eosinophils, although certainly it's difficult to make a diagnosis if that's the case. As I said, we often see clusters or microabscesses of eosinophils, and we often see degranulated eosinophils and superficial desquamation of the epithelial cells. So here's another biopsy of a patient with eosinophilic esophagitis. You can see in the larger picture there that the basal zone layer is quite thick. There's very little cytoplasm in many of these cells. And on the upper right-hand side, you can see that there are several intraepithelial eosinophils, and I think you can perhaps appreciate a clear space between the cells or intercellular edema. You can see the lamina propria down at the bottom of the epithelium there as well. It's kind of thick, it looks fibrotic, and there's scattered lymphocytes and eosinophils on that as well. Here's some other examples of patients with typical findings in eosinophilic esophagitis. In the upper left, you can see superficial layering and microabscesses and sort of desquamation of the superficial epithelium. On the upper right-hand side, you can see numerous degranulated eosinophils, and which raises an issue sometimes for pathologists. We're trying to count the number of eosinophils in a high-powered field, and we see a high-powered field like this. Frankly, it's very difficult to count the number of eosinophils there because there's so many degranulated eosinophils. It's difficult to count an eosinophil as a single cell when it doesn't have any granules and when you just see smears of free eosinophil granules. In the lower right-hand side, you can see marked basal zone hyperplasia and elongation of the vascular papillae. And on the lower left, you can see a lamina propria again with fibrosis and increased numbers of eosinophils. So these are characteristic features of eosinophilic esophagitis. And as I said, typically in a patient with eosinophilic esophagitis that hasn't been treated, these are seen all throughout the esophagus, in both the distal, the mid, and the proximal biopsies that we receive. Last year, there was a consensus report that recommended pathology reporting criteria, and that report recommended that all abnormalities associated with eosinophilic esophagitis be reported, i.e. the peak eosinophil count, the presence or absence of eosinophilic microabscesses, whether or not there was superficial layering of eosinophils, degranulated eosinophils, the extent of the basal zone hyperplasia, whether or not there was dilated intercellular spaces or edema, and whether or not there's lamina propria fibrosis. The recommendation was also made to take multiple biopsies from the proximal and distal esophagus. And typically at Rady Children's, most of our endoscopists take 3 or 4, sometimes more biopsies from both the proximal, the distal, and the mid-esophagus. Recommendations, as I said, were from the proximal and distal esophagus. And it's probably no surprise that the number of biopsies that are obtained, the more biopsies we get, the more likely we are to see a threshold number of eosinophils to make a diagnosis. However, there haven't been any prospective studies that have determined a threshold number of eosinophils that can firmly establish a diagnosis of eosinophilic esophagitis with a high degree of sensitivity and specificity, as Dr. Aceves has noted. So what else could be in the differential diagnosis when we see eosinophils in the esophagus? Certainly reflux esophagitis or GERD is probably one of the most common things that we see and one of the most common things that pediatric gastroenterologists or pediatricians are concerned about. Eosinophilic gastroenteritis may also be present, in which case we see eosinophils all throughout the GI tract. Certain infections such as Candida, cytomegalovirus, or herpes, in addition to the characteristic findings that we see, can also have an eosinophilic infiltrate. Inflammatory bowel disease, particularly Crohn's disease, may cause eosinophils in the esophagus. Trauma, graft versus host disease, connective tissue disorders, and reactions secondary to drugs such as nonsteroidal anti-inflammatories or chemotherapy can also cause an eosinophilic infiltrate. So the differential diagnosis is quite large. With reflux disease, the other changes are typically seen that we see with eosinophilic esophagitis as well. That being basal zone hyperplasia, intercellular edema, we may see increased mitosis in the basal layer, and elongation of the vascular papillae, as well as some other changes. Generally, with reflux disease, the number of eosinophils is less than it is in eosinophilic esophagitis, but there's certainly overlap. The distribution is generally a little different as well, with reflux disease tending to be much more prominent in the distal esophagus, with only small numbers, if any, eosinophils in the mid or proximal esophagus. We may also see a small number of lymphocytes and neutrophils in patients with reflux disease. Here's a biopsy of a patient clinically thought to have reflux disease, and again, you can see just small numbers of eosinophils here, the cells with the bright red granules in the cytoplasm, and there are only small numbers here. Here's another biopsy on a patient which was starting to have candida. Again, you can see small numbers of eosinophils in the base of the biopsy, and in the superficial portion, and this is a PAS stain, you can see several yeast and hyphae typical of candida. Patients with eosinophilic gastroenteritis, in addition to having eosinophils in the esophagus, as we noted, can have eosinophils throughout the GI tract. This is a gastric biopsy. You can see numerous eosinophils, the cells with the red granules all throughout the lamina propria, the area between the glands in the biopsy. And you compare that to the normal in the right upper corner, in which very few inflammatory cells are seen in the lamina propria. And those patients can also have increased numbers of eosinophils in the duodenum as well as other parts of the GI tract. So just to hopefully illustrate some of the difficulties we may encounter as pathologists when we see a patient with eosinophilic esophagitis or with eosinophils in the esophagus, I'd like to briefly present a case history. This is a 12-year-old boy with a 4-week history of periumbilical abdominal pain. The pain usually occurred after meals. He had no history of nausea, vomiting, diarrhea, or a decrease in appetite. His past medical history showed that he was diagnosed with asthma at age 9 and had a possible allergy to peanuts. Endoscopy showed that there was some mild furring in the esophagus, and they did an upper and lower endoscopy, and the stomach, the duodenum, and colon were normal according to the endoscopy note. We received 2 biopsies from his esophagus. One of the biopsies two biopsies from the distal esophagus. One of them is shown here and shows no evidence of basal hyperplasia and only small numbers of eosinophils. There's one in the right upper corner, just kind of under the nose, for no basal hyperplasia. But the other biopsy from the distal esophagus at the same level showed marked increase in the number of eosinophils, more than 50 per high-powered field, as well as some basal hyperplasia. And I think if you were just to look at this biopsy alone and not see the other biopsies, certainly one would entertain a diagnosis of eosinophilic esophagitis. And that's perhaps what he might have, but the picture's a little more complicated than that. The gastric biopsy showed a small focus of chronic inflammation, but not an increased number of eosinophils. And his colonic biopsy showed increased numbers of eosinophils, not large amounts and not a whole lot in the surface epithelium, but certainly more than we typically see. So what's the diagnosis? So does this patient have eosinophilic gastroenteritis, eosinophilic esophagitis with sort of nonspecific gastritis and nonspecific changes in the colon? Do they have reflux disease with gastritis and nonspecific changes in the colon? Could he have inflammatory bowel disease, or could he have a combination of more than 2 diseases? We really can't tell from looking at these biopsies. He was treated with a proton pump inhibitor and given tapering steroids. A few weeks after his initial biopsies, he had a capsule endoscopy which showed aphthous ulcers and fissures in the colon. And because of that, the gastroenterologist thought that he probably does have inflammatory bowel disease, but it's still sort of debatable. Given the number of eosinophils in one of the esophageal biopsies, one wonders if he doesn't have some aspect of eosinophilic esophagitis as well. So it's not always straightforward in terms of what we see under the microscope. So it's, as Dr. Seva said, this is a clinical pathologic diagnosis. Taking into the histologic findings, the clinical findings, and a diagnosis cannot be made on histology alone. As I said, with few exceptions, 15 eosinophils per high-powered field is considered a minimum for a diagnosis of EoE. Unfortunately, right now, endoscopy with biopsy is currently the only reliable diagnostic test for EoE. So as it was said in the consensus recommendations, EoE or eosinophilic esophagitis should be diagnosed by clinicians taking into consideration all clinical and pathologic information. Neither of these parameters should be interpreted in isolation, and that's probably well illustrated by the patient that I presented.